Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about an oral medication in moderate to severe plaque psoriasis and its 4-year data. Our moderator this evening is Dr. Leon Kircik, who's the president of the International Dermatology Education Foundation and clinical professor of dermatology at the Icahn School of Medicine in Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director at Physician Skincare, DermResearch, and Skin Sciences in Louisville, Kentucky. Our presenter this evening is Dr. Neal Bhatia, who is director of clinical dermatology, Therapeutics Clinical Research in San Diego, California. We'd like to thank our supporter, Bristol Myers Squibb, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser as well as being sent to you by email within 1 to 2 days. We'd greatly appreciate it if you would fill it in and send it back to us. And within 1 to 2 days of the webinar, a certificate of attendance will be sent to you. Again, if you have any questions, please write your questions in the question chat pane on the right-hand side of your screen. So without further ado, I will pass the floor virtually to Dr. Leon Kircik.
Thank you, Roxanne, and good evening, everyone. Thank you for joining us for another International Dermatology Educational Foundation educational webinar. And greetings from Montauk, New York. And tonight we are very lucky to have my good friend, Dr. Neal Bhatia. But before we go to the program, I just want to introduce you IDEF very briefly. IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. Since the pandemic, we have come to your houses, to your offices virtually within several programs, including in US, but as well as in Canada, South America, Southeast Asia, as well as Europe. So also now we are up to, please stay up to date with us at IDEF Derm at Instagram, as well as Facebook, as well as LinkedIn. So please visit www.idefeducationseries.com to register for upcoming educational events. Tonight, as I mentioned, we have my good friend, Dr. Neal Bhatia. We could not have enough of him last week, so we invited him back this week. And he's gonna tell us about this new oral medication in moderate to severe plaque type psoriasis, but most importantly, the last 4-year data, the efficacy and safety. Welcome, Neal. Thank you.
Thank you, Leon. It's a pleasure to be with you 2 weeks in a row. I'll thank everyone in the audience and definitely thank Bristol Myers Squibb for sponsoring this version of the IDEF webinar series. As a background, my job is clinical research primarily, as well as seeing patients. We were part of the POETIC 1 and the long-term extension trial for deucravacitinib, and I've been a consultant for Bristol Myers Squibb for some time. And it's a pleasure to bring you this conversation about Sotyktu, which is, again, oral therapy redefined for moderate to severe plaque psoriasis in adults who are candidates for systemic therapy or phototherapy, which we'll talk about. My goal is to, again, go over some data as well as some new safety data over 4 years. These are some of my relevant disclosures. And again, this is a promotional program, not for CME, but it's for, again, the Bristol Myers Squibb sponsorship. So the understanding of pathways is very important when you think about the mechanism of action of these therapies. The idea that we are targeting now the conversion of proteins, which are, again, the pivotal cytokines that make psoriasiform plaques, that are also, again, looked at as where can the medications work, is a pivotal discussion to have with the patients. You want to talk to them about not suppressing their cells, not depleting the cytokine populations, but instead changing the conversion of how the other cytokines that do the job are made so that, again, the safety is still there and yet the efficacy can be discussed for the long term. take a look at how interleukin 23 is processed to make interleukin 17 the effector cytokine. You see the binding of the intracellular receptor, the processing through the JAK-STAT pathway of what tyrosine kinase 2 is the primary driver. And from there, the conversion of the genome to make the cells, to make the processing of interleukin 17 comes into play. You're familiar with the Janus kinase STAT pathway for other conditions such as atopic dermatitis, vitiligo, and what have you. Tyrosine kinase 2 is different because the metabolic effects that involve lipid metabolism, hematopoiesis, leukopoiesis, and some of the other important metabolic issues are not part of what tyrosine kinase 2 modulates. Tyrosine kinase 2 only has immune effects that are effective in the skin, and there's a specificity for interleukins 12 and 23 for those cytokines to be what tyrosine kinase 2 targets in terms of processing. Even though it's paired with a Janus kinase 2, as you see here, it's still not the primary target for deucravacitinib. So again, it's the discussion of what is the target, which is tyrosine kinase 2, and then of course how it impacts the processing of how you get from interleukin 23 to 17. What you need is phosphorus for 4 pivotal steps: the dimerization of the receptor, the binding of the cytokine to that receptor, the binding of the STAT protein to take that messaging to the nucleus, and then phosphorus is necessary for transcription to make the 17 product. So 4 important steps where you need phosphorus, which is what a kinase does. It makes phosphorus. Now, as you see what Sotyktu is doing, it's inhibiting the activation of tyrosine kinase 2 in that regulatory region, but not affecting the ATP region, which I'll show you more up close in a second. Because that regulatory region is bound by the drug, the kinase cannot do its job. The activation of the STAT protein cannot happen downstream, and therefore that processing of the genome to make 17 is stopped in its tracks. But what you don't see is inactivation of that lymphocyte or the dendritic cells that are processing it from further upstream, nor do you see a depletion of this population of 23. So it's allowed to do other things. So those are 3 important things to keep in mind of what's not happening. From that, again, the pseudokinase domain or the regulatory domain is the target of deucravacitinib, whereas for many other Janus kinase inhibitors, the active ATP site is actually the target. And as you see, there's a homology in all of the ATP binding sites with the Janus kinase family. So in this case, where you see deucravacitinib binding, it's a very different activation site of the drug doing its job, versus where phosphorus is binding and being made on the active site. So it's real important, even though they're part of the same family, they're all structurally different, as you see. And like I said before, even though tyrosine kinase 2 is paired with the Janus kinase enzyme, the inhibition effects of deucravacitinib are solely going after the tyrosine kinase 2 site. So it's important to keep that distinction in hand. So I hope these diagrams make some sense on the mechanism, because it's real important for describing the safety. And as I mentioned, here's tyrosine kinase 2 working again on the immune system processing, but you don't see any impact on hematopoiesis, on other metabolic actions, and then of course on lipid metabolism, which is what you do see with JAK1, 2, and 3, which is why we get blood tests and labs for the sequence of their treatments. But with tyrosine kinase 2 inhibition, those effects are not as significant or not even present, which is why we don't see the need for laboratory testing to follow the impact of the drug. Excuse me. As an aside, I mean, many of us get lab tests to chase the disease, to follow what's under the hood of psoriasis, if you will, but we don't necessarily follow them for the safety of the therapy. So that's why a lot of dermatologists still get blood tests, but for a very different reason, and also for, again, compromising the patient is not what we want to do. This also goes back to, again, the specificity like we see here on the left. You see at least tyrosine kinase 2 being selectively inhibited by deucravacitinib, but the others, again, Janus kinase 1 and 3, Janus kinase 1 and 3 in the middle with tofacitinib, upadacitinib, and baricitinib, again, have very different specificity for Janus kinase 1, 2, and 3, but there's no effect on tyrosine kinase 2, as you see there. So again, the 50% inhibition of tyrosine kinase 2 by Sotyktu shows you the specificity of its binding site, as well as, again, working on the regulatory domain and not the ATP domain. So that's real important to recognize why tyrosine kinase 2 is important for psoriasis and why Sotyktu is important for treating patients with psoriasis, because it's a very special and specified process. So let's switch gears clinically and think, who is a candidate for systemic therapy? Who are people we want to treat inside out? We talk about this a lot with patients who've been on different therapies. You talk about surface area, maybe the areas on the back, which is harder to reach with topicals, maybe a lot of thickness of the plaques that are not responding to the right ointment or gel or whatever vehicle the topical agent is in. And even more so, we think about the fatigue that patients have been through of just using ointments or just treating top down. So think about a patient like Seth, for example. He's a little bit heavy. He's had psoriasis for about 2 years. He's got hypertension. He's got, a family history of IBD, and again, inflammatory bowel disease is very closely linked to sometimes with psoriasis. But you also see 10% of his body, his PASI score is 12, and he's graded as a moderate patient. But even more so, again, creams haven't been doing what he had hoped. He's looking for an option that he doesn't have to just put on. So how do we talk to him about, again, how do we treat inside out, if you will? That's kind of the way I phrase it to these patients. Part of it is, again, is that Sotyktu is once a day, which is good for his lifestyle. We've seen the head-to-head, and we're about to see the head-to-head of deucravacitinib against apremilast, which is a BID drug also. And now we have 4-year data that shows significant safety profile in the clinical research element, and that's what we're also going to be looking at. This is the way the two trials were designed. You see the SO1 and SO2 trials. They're a little bit different in terms of who got what after the pivotal part of the study. So if you look at the patients who were randomized 1, 2, and 1, out of all the patients, 1 of them got placebo, 2 got active drug deucravacitinib or Sotyktu, 1 got apremilast. They had to take dummy pills so that they were blinded, right? So they were, even though they got Sotyktu once a day, they still took a dummy pill to not reveal the blinding. But if you look at their 16 weeks, the pivotal part of the endpoint, then those patients were reshuffled, and the patients who were on apremilast ended up either back on apremilast or they were randomized to Sotyktu from 24 weeks on. The placebo patients were all rolled into an active Sotyktu group, and then the Sotyktu group stayed on active drug. But in the SO2 trial, there was a little bit of a decision tree on patients who either achieved PASI 75. They were either rolled straight into Sotyktu 6 milligrams a day, or they were given a washout time of placebo and then Sotyktu 6 milligrams a day. But if they were less than PASI 75, they were automatically put into active drug. The apremilast group, again, if they were PASI 75 or greater, they were washed out for a little bit with placebo and then put into Sotyktu 6 milligrams a day, or if the PASI score was less than 75, immediately rolled into 6 milligrams once a day. So the design was meant to look at what happens if there's a little bit of a gap in therapy, but also, again, what would happen with conversion from one active drug to the next. So a lot of different questions being answered in all of those study designs. They also looked at specific scalp diaries. They looked at scalp scores, and they also looked at, again, the time for PASI score improvement. So also very important again. So in the end, the Sotyktu patients, of those, in the SO1 and the SO1 trial, you see the PASI 75 score with almost 60% versus 13% compared to placebo. In the SO1, again, the STPGA, or the grading of 0 and 1, 54% were graded as clear or almost clear, which is also very important. Think too about timelines. So I look at this slide and I think, excuse me, I think, okay, what's the timeline for seeing the ascent of when the patients are getting better? And you look at it right around 4 weeks, right around 8 weeks, you start to see the separation from placebo, or sorry, from apremilast, as in this case. And then at 16 weeks, you see a very significant difference of 58% versus 35%. And then at 24 weeks, 69% versus 38% of the response rates. So again, there's a cumulative effect of going, downhill of how many patients are continuing to get better and more of them. And even more so, I would say, okay, would I want to see patients back at 4 weeks or 6 or 8 weeks? I'd probably want to see them back closer to 12 weeks, because that group is going to be a larger subset that gets better compared to those patients I might start on apremilast, and they wouldn't be in that population. So I would probably start them on drug, maybe see them back in about 3 months, and they would probably be in the percentages that say, yeah, I'm doing better. So real important there. And again, you know, the number of patients who were achieving PASI 75 and maintaining that was also very important. PASI 90 was also measured, and again, you know, you see quite a bit of separation between 36% and 20% of the Sotyktu group versus the apremilast group, 42% at week 24 compared to 22%. So a very durable and yet significant improvement to PASI 90, and even more so, you had patients who were PASI 100. So we learned from the pandemic the importance of taking pictures, especially for telehealth and, you know, patients submitting images. One of the rules of thumb was not to put your foot up on an ottoman with both the rug and the floor, so that you can't really see the pictures. And yet the pictures here actually do tell 1,000 words in terms of their improvement. You look at the pretibial surface, how much is there at the baseline? You look at week 16, how much significant improvement there is in the erythema, the plaque elevation, and the scale, which are important parts of the PASI score. By week 24, even more significant, you know, improvement with less erythema and less epidermal change. And by 1 year, the patient's almost clear. I mean, I'd probably say it's clear. So again, even though the ideal scenario, the photos was not great, at least they were done consistently throughout the 1 year, and you still get to see the image of that patient's clearance, which is really important. Now let's think about the 4-year data. So you get, again, the patients who completed the pivotal trial, they were completed the 1 year data set, and then they were rolled into the long-term extension for, again, over 4 years, and then into 5 years. Excuse me. And then again, what you're seeing here is that durability of response through 4 years. You see, again, you know, the number of patients achieving PASI 75 and PASI 90 at 52 weeks, and it's right around maybe 70-some%, maybe close to 80% for this in some areas, but 72% at week 52, 46% at PASI 90. At week 208, it's pretty much the same, the ones who achieve PASI 75 and PASI 90. So really a very durable response. You know, there's, you know, once patients continue on drug for that time, they're not losing anything. They don't lose their gains, and that's real important also. I mean, again, this is you know, the limitation of a long-term extension is that patients who lose response are likely to stop treatment, so they drop out, and that may raise the number of responders overall. But at the same time, you do see that steadiness in terms of where they're fitting. So I think that's really encouraging to think, yeah, I can not only make things stay away after a year, but I can make them, you know, continue to stay away at 4 years or longer. So that's real important here. Let's look at someone like Sadie, for example. So Sadie's 34. She looks like a travel nurse. She travels a lot for work. She needs something that fits her lifestyle, which probably would go against shots and probably go against creams, given her, or ointments, given her surface area. She's had psoriasis for 4 years. She's got a heavy scalp line and a hard line on her, you know, knees and her lower legs. You see that she's been using shampoos at least, as well as topicals, for over 3 years. She does have hyperlipidemia and a history of diabetes in her family, but she needs something that she's going to stick with, because you look at the amount of surface area she has, and she really has a lot of trouble, especially getting into the topical treatment of a lot of these. So what's nice is, from what we learned from the SO1 data, you see the scalp response, which was teased out by the scalp diaries and the PSSDs. You look at 70% improvement on those who were taking Sotyktu once a day, compared to apremilast 30 milligrams twice a day, which was 39%. So a twice a day drug only got them, you know, 39%, versus a once a day drug got them 70% clearance. So that's really something to be significant for. And again, in the SO2 trial, you know, the SSPGA was 60% at week 16 versus 37%. Shows you there's a significant difference at that timeline. More importantly is, again, a once a day drug, you know, that's easy to stick with for a travel nurse like Sadie, and even more so, this efficacy number will convince her that, yeah, I mean, maybe the pills are for you, and we don't have to deal with shots. And I think here too, you'll get patients who will look at how they were clear and almost clear. So again, the palmoplantar data is really strong, and that's, again, very debilitating for a lot of patients. So again, look at the 0% versus 56%. That's, again, quite a bit of response difference. Same thing in the SO2 trial, 46% versus 24%. It's quite a bit against placebo. Bottom line, again, is, the scalp, the palmoplantar areas, these are very tough to treat areas. This is where, again, patients may be thinking, should I be on shots? Is there something else that's going to help? I mean, do I need to be on different topicals? But again, these are real patients who took deucravacitinib through that time frame. And even as early as week 2, you see the amount of surface area that improved, the amount of epidermal change that improved. And again, by week 24 and week 52, they're already, close to zero in terms of how much activity they have left. So again, this really tells us a lot about the efficacy as well as the timing of when you'd want to see the patients back, but also what they should be expecting. And then as far as adverse events at week 16, again, upper respiratory infections are going to happen in clinical trials. There was very little in terms of CPK increase and suggestions of rhabdomyolysis. You have very little in terms of herpes, of oral ulcers, very little folliculitis and acne that went along with it. And again, they occurred in less than 1% or so TIC2 with again with herpes zoster. So that's also very important. This is again at week 16. 2.4% of the patients who had adverse events ended up discontinuing. But again, these are these are numbers that show adverse events occurring in 5% or more in any of the active group. There were more, almost double the number of apremilast patients who dropped out in comparison to the Sotyktu patients who dropped out for upper respiratory infections, nasopharyngitis, headache, diarrhea, and nausea. So again, very little bit. Obviously, the GI effects, they are part of the apremilast literature and are in the package insert, but also part of the patient experience for those who've written apremilast and they know the dose-limiting effects. Now let's look at a year-long data. And again, the number of adverse events, the number of serious adverse events in the Sotyktu group compared to the apremilast group was, again, a little bit higher. But again, remember, there were more patients. There were 1,364 patients versus 422. And again, there was really pretty equal incidence of respiratory disorders as well as many more GI effects as seen in the apremilast group as compared to the Sotyktu group or the placebo group. Even more so, again, there were 1,600 patients randomized to receive Sotyktu, and all of them switched to Sotyktu at week 16. So again, lots going on in terms of the randomization of patients into the different active groups. And then, of course, in that age group, in that treatment group, there was pneumonia, there was COVID-19, obviously, the timing, and then, of course, those patients were being screened for skin cancer as well as other malignancies, as well as, again, third year, listing how many patients actually had lymphoma. There were only 3 patients. So take a look at these graphs. They show you again, the incidence of the 3 agents that were studied. Of left to right, you look at non-melanoma skin cancer, you look at malignancies that were you look at non-melanoma skin cancer, and then you look at non-skin cancer malignancies. You look at the number of serious infections. Again, pretty even amounts between Sotyktu and apremilast. Again, a little bit more apremilast involved with the malignancies in the non-skin cancer. A little bit more zoster that was seen in the the Sotyktu group. A little bit more venous thrombosis and, again, the arterial thromboembolic events. And then the MACE events, very, very less in comparison to apremilast. So these, again, are also not significant enough to, again, make for 2, the rate per year being twice. So again, it's really significant to look at the safety based on some of these numbers. And this is where we get into 4 years. So you look at some of the numbers of adverse events and categories of adverse events and the number of patients. Again, there were, again, 969 patient years compared to 2,482 for the cumulative years. And again, just very important to recognize how few adverse events that led to discontinuation and, very few that patients who passed away during the trials. It was only 0.4, 0.2 that were related to adverse events. And then, of course, patients who had other experiences, they were out of the trial, but also, again, they had nasopharyngitis, headaches, arthralgias, and diarrhea, of course, which is higher in the apremilast group. But this is now just looking at the Sotyktu group over that time frame. Very little in terms of those effects. And in fact, through year 4, you look at the cumulative effects, very little in terms of the number of adverse events overall. So again, looking at year 1 of year 4, important for, again, the number of patients with COVID-19, but again, look at the number of patients with anything that were there. And the other thing was there was only 2 deaths during the study. The other part of the equation, again, there were no new safety signals that were observed through year 4. And again, you look at the left side of the graph, number of serious infections, herpes zoster, MACE, venous thromboembolic events, total malignancies. These are all part of the box warning disease states that are part of the other Janus kinase family. And you see here, there are very low incidence of any of those in tyrosine kinase 2 inhibition, which is again why there is no box warning for Sotyktu, because those incidences of adverse events are extremely low. Excuse me. So you look at rhabdomyolysis, and there were a couple cases that were reported. There was a 31-year-old female who, during the study, began a very intensive exercise program. You know, it's kind of a tribute when the psoriasis is getting better, they can actually get better in exercise. But by day 15, the patient was experiencing significant pain that was consistent with rhabdomyolysis. Her renal function remained normal, but the treatment had to be stopped for 6 days. The labs then were taken again, and she eventually completed her treatment and was enrolled in long-term extension. But the other case, a 64-year-old male with multiple comorbidities, had a right popliteal arterial thrombosis, a little bit, and then was diagnosed with compartment syndrome. That resulted in again, regional rhabdomyolysis, and they stopped all treatments, and again, the events all resolved after surgical management. But again, that's a rare case, even though the patient was 64 and had that happen. So again, the take home is in the 16-week placebo-controlled period, increased CPK was reported in 23 patients. You know, some were treated, again, those were treated with Sotyktu versus 5 that were treated with placebo. The other thing is with liver enzymes, there were events of increases in the liver enzymes. And again, the number of values were observed in patients who were on Sotyktu. The ALT and AST elevations that were 3 times the normal. Again, 9 of those patients, 13 of those patients were part of Sotyktu, and 2 each were part of placebo. Point of exercise again is we watch these, but in the we watch these in the Janus kinase enzyme inhibitor family. But for tyrosine kinase 2, these are rare events that again has led to the warning that you don't need to check the labs. You just check, again, their symptoms and follow their course. So again, this is week 0 through 16. You look at the lab abnormalities, excuse me. Lymphocyte, neutrophil, and platelet count decreases, anemia, changes in the lipids, changes in the triglycerides, changes in CPK, creatinine, and then the 2 liver enzymes. Again, very similar to placebo in terms of the Sotyktu group, as well as the apremilast group that you see on the right. But again, there were more Sotyktu patients that could have skewed those numbers. And the idea is that, again, the very few issues that went along with it in terms of lab abnormalities. Which is why, again, at 4 years, you see the ALT level, it's followed a little more closely during the pivotal part, and then at week 52, it slowed down. Excuse me. And then what you have there is, again, very steady in terms of the number of patients who, again, what were they looking at? The mean and plus or minus the standard deviation was right between the upper limits and lower limits of normal. This was in all the trials as well, the SO1, SO2, and the poetic long-term extension. You look again here at week 52, again, the lab frequency is a lot less, but again, a very steady display of the mean values of AST throughout the trial, both from the upper limit and the normal limit, the lower limit. Same with the triglycerides. Again, you're seeing those fasting numbers taken through week 24, again at week 52, week 100, week 148, and 186. There's no real change in the mean value of the triglyceride numbers, which again is real important, because that's what we worry about with some of the other JAK inhibitors. Same thing with total cholesterol. You see the flat line there. And you see the CPK staying within upper and lower limits of normal. But this is, again, all through 4 years of being on the drug. So really the safety data is there and it speaks for itself. It's just that, again, now that we learned all this in clinical research trials, we don't have to check those labs as in clinical practice unless there's an issue. For example, patient comes in with sudden onset pain, I would be checking CPK to look for any evidence of rhabdomyolysis. But otherwise, I would know that there's a safety that goes with it. Same thing with the creatinine levels here. As you see, again, they're very steady throughout the 4-year time frame. And then, of course, the hemoglobin and the rest of the heme parameters, also the lymphocytes, they were also very steady. And then the neutrophils would follow. So again, excuse me, it's important to recognize the safety issues, but again, the right candidate needs to be educated on what to look for, needs to be educated on the safety of oral therapy, and then even more so just follow it appropriately. But the good thing is, without the box warning and with no real safety signals that we have to really be concerned about from labs, patients might feel more at ease, as well as the dermatologist might feel more at ease for writing these drugs and keeping those patients on for 4 years and keeping their psoriasis under control. So again, let me go back to the other slide. Pardon me. Again, hypersensitivity reactions were reported in the trials. Again, institute appropriate therapy and have them watch. One thing we like to do is have them take the first dose of Sotyktu in front of us. We have them sit and wait for about half an hour while they fill out the enrollment paperwork and everything else. It actually makes sense because we're watching them for the first half hour. Then we can tell them, okay, there's no sign of any hypersensitivity response. So it looks like we can send you home. We do have to remind them about infections, and especially if they've had a history of chronic or recurrent infections, any exposure to tuberculosis or anything opportunistic. And even more so, we want to just have them watch for any unhealing wounds or anything that's going to cause a fever. Again, viral reactivation in terms of herpes zoster and simplex was reported in the clinical trials. There was, again, 6.8 per 100 patient years treated with Sotyktu who had developed herpes simplex infections. One who was in the placebo group. Again, the impact of Sotyktu on chronic viral hepatitis reactivation is unknown. And again, we just don't want to treat anyone who's got active hepatitis B or C. With tuberculosis, again, there were patients who had latent TB that were treated. They received appropriate TB prophylaxis. One patient who did not have latent TB, again, developed active TB after receiving 54 weeks of Sotyktu. So again, in an endemic area, you want to make sure you're testing properly. Have patients watch for any sign of cough. Not like my cough. This is a sign of me talking to you guys, but there we go. Excuse me. And of course, anything that goes along with a change in their health, their weight, that could signal that there needs to be suspicion for lymphoma. We talked about the joint aches, the muscle aches that should, mandate a check of the CPK to make sure there's no issues with rhabdomyolysis. And then we talked again about some of the laboratory abnormalities, including the triglycerides. And we saw the 4-year data where everything stays very steady. Make sure you get the proper immunizations. Again, these are adult patients for now. So again, make sure they're age appropriate. The zoster vaccine is probably the most important one. I usually have them get it a week before they're going to start, maybe even 2 weeks. And then after 6 months, they should be clear enough that you can take a holiday and they can get their other vaccine series right around that time. Same thing with the risks, related to JAK inhibition. We can tell, again, these are things that we want to watch for. Again, the concept of the box warnings were patients who were treated, they were 50 and up with rheumatoid arthritis, and they were treated with a TNF inhibitor, as well as those compared to it. But with Sotyktu, we don't have indication for rheumatoid arthritis, so that's not going to happen. Again, the common adverse reactions, looking for anything with upper respiratory infections, changes in the CPK, herpes simplex, mouth ulcers, folliculitis, and acne. There's really no evidence for supporting it in pregnancy or in breastfeeding. So if there is a plan to get pregnant, or if they're currently pregnant, I tend to not put them on these drugs, just because we don't have any real evidence to support it. So again, once a day simple dosing, superior efficacy against twice a day apremilast. And we talked about the 4-year safety data, which I think is the most pivotal part of today's discussion. You look at the lab values for 4 years, you look at the adverse event profile for 4 years, and you match that to the success and the efficacy over 4 years and how well patients did. Again, this gives patients more control because they're taking a pill every day. You think about that patient Sadie who is going to be traveling. You think about Seth, who's not really happy with just topicals alone. And again, this is a patient where you don't have to worry about drug interactions. They can take it with or without food. Again, the TB evaluation is, we check for patients who've had a initiation or some other issue. And then, of course, the 10-hour half-life really allows for some flexibility. Again, I think about triglycerides. If someone were heavy, they had metabolic syndrome, I'd probably be checking it anyway, or at least somebody else would. But there's really not the same impact on triglycerides like we see with some of the other JAK inhibitors. So again, someone with a history of suspected TB, check their liver, check their baseline, check their immunization, check their TB test, get them started on treatment. Like I said, we like to do it in the day with the patient in the room. Bristol Myers does have a very good Sotyktu 360 support. Patients get a free 30-day supply or a starter pack. They're also a bridge program that they can get up to 3 years. And then finally, the copay assistance program is zero, and eligible patients, so those who are commercially insured, should pay as little as $0 per month for this agent. Okay, so what would these patients ask? Well, I mean, we talked to them about the safety. We talked to them about the systemic approach. Sadie, especially the traveler. Seth, who's got topical fatigue. What other data should they be aware of? We talked about being on it for 4 years safely. We talked about getting started. We talked about the safety during the year without having to check for labs. Even more so, again, we want to just talk to them about their improvement and what they can expect. And again, that improvement timeline, looking at again around 16 weeks, we can tell them that in the trials, 72% of the patients who were on the drug, again, got better and significantly better than those placebos, or those patients who took placebo in that trial. These are a little bit better photos than the guy on the ottoman. I'm sorry, but I liked these a little bit better. And you can see the plaques. Again, you see the significant improvement of the plaques already at week 2 with the reduction of the erythema, and then the scaling and everything else around the right knee really starts to fade by week 24. And by week 52, this patient's clear. I mean, this is really what we're trying to accomplish. We want them to get clear, and we want them to stay clear. Same thing on the lower leg and around the knee. You see the significance of those plaques and how much they really could hurt, as well as how much they're, how stubborn they are, basically, against their topical counterparts. Same thing with the elbow here. Again, this is a high risk place for steroid atrophy. The place on the knees is very difficult for someone to reach. So really, again, working from inside out is really going to be helpful, especially with this patient who's got the knees and the elbows. They've been probably trying triamcinolone ointment for some time, and there's a lot of fatigue that goes with those topicals. Same thing with the right knee here. You already see some significant change with post-inflammatory erythema being left over, and then the knees themselves, again, how much improvement there is right from there. And these are real patient photos. So we went through some of this already, and I just want to tell everyone thank you for your attention. And there's a QR code that you can download or take a picture of for some additional information on Sotyktu, and I think we're good. So Dr. Kircik, I'll send it back to you.
Thank you so much, Neal. I guess you're so much wanted because you always finish early. So thank you so much for an eye-opening lecture. Again, really well done. Every time I listen to it, I learn something new. I'd like to thank our supporter, Bristol Myers Squibb, that made it possible, this educational event. And also, I'd like to make you aware that our next program is going to be with Dr. Brett King. It's going to be the burden of alopecia areata, a patient journey, on July the 23rd, 7 p.m. Please join us. Thank you again, and have a good night, everyone.
Night, everybody.
Bye.